is Anthony Gon, and I will talk about non-alcoholic fatty liver disease, insulin resistance, and ceramides. Definition: alcoholic fatty liver disease, or NLFLD, is the buildup of extra fat in liver cells that is not caused by alcohol. It is normal for the liver to contain some fat. However, if it is more than 5% or 10% of the liver's weight is fat, and then it is called fatty liver steatosis.
Non-alcoholic fatty liver disease is actually a spectrum of disease, going from least to most severe, steatosis, steatohepatitis, fibrosis, and finally cirrhosis. Non-alcoholic fatty liver disease results from fat deposition in the liver, which is unrelated to alcohol or viral causes. Typically, it affects individuals with metabolic syndrome, which includes a combination of 3 of the 5 following diagnoses: obesity, hypertension, diabetes, hypertriglyceridemia, and hyperlipidemia. Given how common metabolic syndromes become, it's not surprising that the rate of non-alcoholic fatty liver disease has also increased dramatically. It's a massive problem, growing in lockstep with expanding waistlines, affecting about 3/4 of all obese individuals, including many children. Although the exact mechanism of non-alcoholic fatty liver disease isn't clear, insulin resistance seems to play an important role. Over time, insulin receptors on various tissues, including the liver, become less responsive to insulin, and as a result the liver goes into a mode where it increases fat storage and decreases fatty acid oxidation. That means decreased secretion of lipids into the bloodstream, in the form of lipoproteins, and increased synthesis and uptake of free fatty acids from the blood, a process called steatosis. Steatosis causes fat droplets to form within hepatocytes, some of which become large enough to cause the hepatocytes to swell up with fat and push the nuclei to the edge of the cell. You can even see this on a histopathology slide of the liver. All these white circles are large deposits of fat. Zooming out and looking at the liver, you see widespread steatosis, which makes the liver appear large, soft, yellow, and greasy. Over time, that fat in the hepatocytes becomes vulnerable to degradation. Unsaturated fatty acids, or fatty acids that have at least one double bond in their carbon chain, have hydrogen atoms that are especially vulnerable to initiators, like reactive oxygen species, like the hydroxyl radical, which has an unpaired electron. In this example, the hydroxyl radical pairs with the vulnerable lipid hydrogen to make water and a fatty acid radical. The fatty acid radical is unstable and reacts with non-radicals, including molecular oxygen and undamaged fatty acids. This goes on until one radical species reacts with another radical species, which terminates the reaction. This process damages lipid membranes, leading to things like mitochondrial dysfunction and eventually cell death. Cell death generates inflammation, and together the process of steatosis and inflammation is referred to as steatohepatitis. In the absence of alcohol, this is called non-alcoholic steatohepatitis, or NASH. In addition to bloating and dying hepatocytes, there might be additional histopathologic changes like the presence of Mallory-Denk bodies, which are tangles of intermediate filaments that can be seen in the cytoplasm of hepatocytes. The mechanism, though, for how these form is still unclear. Hepatocyte damage also attracts neutrophils into the liver tissues. And finally, chronic steatohepatitis can cause liver stellate cells to lay down fibrotic tissue, causing the disease to be classified as fibrosis. As the process of fibrosis continues, the overall architecture of the liver changes, to the point where the disease is classified as cirrhosis.
Application in medicine. Insulin is a hormone made by the pancreas, and it keeps your blood sugar level from getting too high. Hyperglycemia. Insulin resistance is a precursor to advancement of causing conditions such as diabetes type 2, atherosclerosis, NAFLD, obesity-associated cancers. In addition, ceramides are a bioactive lipid intermediate which can after membrane be of physical properties.
It's a serious disease caused by a growing epidemic.
Fatty liver disease is a condition that's more common in those children who are overweight or obese, and it's essentially an accumulation of fat in the liver.
Pediatric gastroenterologist Dr. Archie Ramaswamy says fatty liver disease is being diagnosed in children as young as 6 years old.
There are associated conditions such as diabetes, insulin resistance, hypercholesterol.
Children with fatty liver disease typically have no symptoms, so the disease is found through blood work. If severe and left untreated, it can lead to liver failure.
The liver is an organ that also is more sensitive to this fat accumulation also. And it's not based just on a certain body mass index or a certain weight. There are a lot of factors that go into it also.
Other factors like genetic conditions can also lead to fatty liver disease in children.
What I like to do is a full workup to look for other genetic causes of liver inflammation, the elevation of liver enzymes, just to make sure that we're not missing everything. Certainly having a family history of high cholesterol, diabetes, things like that also does make a child more prone to having those conditions, but also to having fatty liver disease.
Limiting sugar and processed foods and encouraging a healthy diet and regular physical activity can prevent and treat fatty liver disease. For Lee Health, I'm Lindsay Morton.
Pros and cons. Pros: knockdown of DEX1 by a small heartbeat RNA could prevent but not reserve obesity in mice. Perhaps augmented mitochondrial function brought about through suppression of DES1 improves whole-body glucose metabolism by reducing ectopic lipid and intracellular lipid metabolites. Cons: various types of lipids are involved, and molecular mechanisms that affect the action of insulin are debated. These pathology include symptoms as malaise, fatigue, sickness, itch.
Alcoholic fatty liver disease, or NAFLD, is a liver disease that is not related to ethanol use, that involves hepatic fatty infiltration. In this lesson, we're going to talk about why this happens, what are some of the risk factors, and we're also going to talk about the signs and symptoms of this condition and what we can do to manage and treat it. So again, it's a liver disease that involves hepatic fatty infiltration that is not related to alcohol. It is a spectrum of macrovesicular hepatic steatosis that eventually leads to inflammation and eventual fibrosis. So essentially, the liver starts to build up fatty deposits. Eventually, it leads to inflammation of the liver. It's an infiltrate, and the inflammation over long periods of time can lead to scar tissue or fibrosis. The etiology of non-alcoholic fatty liver disease is essentially insulin resistance. So I'm going to talk briefly about insulin resistance and why this happens in the liver. So here is a cell that has an insulin receptor, and there is glucose that needs to enter the cell. We need insulin to activate the insulin receptor and allow the glucose to enter the cell. But in a state of insulin resistance, that doesn't work. The insulin receptor doesn't work properly. We can't get the glucose in the cell like we need it to. What happens is glucose starts to increase. Insulin starts to increase. We become hyperinsulinemic. And these have a couple of different things that happen. The hyperinsulinemic state actually leads to activated or increased lipogenesis in the liver. Essentially, the liver will take that higher level of glucose and essentially convert it into fat. And because this is happening at a higher level, the fat is essentially abnormal. That fat-making process becomes aberrant. It leads to fatty deposits in the liver, and this is how we actually get this disease in a simple way of describing it. The risk factors all are associated with insulin resistance. The risk factors for non-alcoholic fatty liver disease include the following: metabolic syndrome, type 2 diabetes, so something with insulin resistance. Both of those have insulin resistance. Hypertension is also associated. Dyslipidemia, you can imagine if there's lots of higher levels of fats in the blood, you can assume that the liver is making them and that there's an associated risk due to that. And what is interesting is that rapid changes in weight, including weight gain or weight loss, can lead to this condition as well, and we're going to discuss this later in the lesson.
In soil plate inhibitor. 15 years ago, doctors said it was common to find cases of fatty liver in people over 45 years. But now, the problem is also present by young people by 17 years old. NAFLD is seen more in adolescents because they are closer to fatty foods and limit physical activity.
Non-alcoholic fatty liver disease is now the most common cause of liver disease in the developed world, largely caused by obesity, and describes a spectrum of disease ranging from steatosis, fat in the liver, steatopatitis, fat with inflammation, non-alcoholic steatohepatitis. Progressive disease may cause fibrosis and liver cirrhosis. Non-alcoholic fatty liver disease is thought to represent the hepatic manifestation of the metabolic syndrome, and hence insulin resistance is thought to be the key mechanism leading to steatosis. Non-alcoholic steatopatitis is a term used to describe liver biopsy histopathological changes, similar to those seen in alcoholic hepatitis, in the absence of a history of alcohol abuse. Non-alcoholic steatopatitis is a silent liver disease, and it is almost always asymptomatic and diagnosed incidentally. The diagnosis is supported by the presence of obesity, hyperglycemia, hyperechogenic hepatic parenchyma on ultrasound, and increased alanine aminotransferase and aspartate aminotransferase. It is relatively common, and thought to affect around 3 to 4% of the general population. It is more common in men due to the protective effects of estrogen. The progression of disease in patients with non-alcoholic steatopatitis may be responsible for a proportion of patients previously labeled as ketogenic cirrhosis. Approximately 20% of non-alcoholic steatopatitis will develop cirrhosis and its associated complications. Associated factors: obesity, hyperlipidemia, type 2 diabetes mellitus, jejunal bypass, nutritional status, sudden weight loss or starvation, or overnutrition and total parenteral nutrition, drugs, amiodarone, methotrexate, metabolic abnormalities, galactosemia, glycogen storage.
Conclusion. Dyslipidemia to be the most important risk factor for fatty liver presentation. The insulin resistance index has a high association with NAFLD, and we propose it is used for early detection of fatty liver in patients with one or more MS factors.
We will be starting our journey with the adipocyte. Adipose tissue is loose connective tissue composed of cells called adipocytes. In the skin, adipose tissue provides insulation, whereas around organs, it serves as a protective padding. In addition, there is increasing evidence on the important role of the adipocyte as an active endocrine and paracrine organ, which secretes a large number of adipokines. Hormone-sensitive lipase is an intracellular lipase, or enzyme, that is capable of hydrolyzing lipids such as triglycerides. Located on the cell membrane are specific receptors for the hormone insulin. Under normal circumstances, when insulin binds to the insulin receptor, this triggers intracellular signals that suppress the activity of hormone-sensitive lipase. Sometimes, for a number of reasons, the intercellular signal following insulin's binding to its receptor is not properly transmitted. As a result of this insulin resistance, the activity of hormone-sensitive lipase is not suppressed. This leads to an increased activity of hormone-sensitive lipase, causing the hydrolysis of triglycerides. When this occurs, glycerol and free fatty acids form as products. Free fatty acids are then eventually released into the circulation. Free fatty acids, released from adipose tissue, circulate in the blood towards the liver. The free fatty acids are taken up by the liver, where hepatocytes channel fatty acids into secretory pathways. In a state of hyperinsulinemia, there is increased synthesis of triglycerides, esterification, shown by the thickened left arrow, with consequent high rates of very low-density lipoprotein secretion into the bloodstream. At the same time, there is decreased oxidation of free fatty acids, shown by the thin right arrow. In blood vessels, the enzyme lipoprotein lipase, LPL, hydrolyzes the triglycerides of VLDL. The products of this are primarily monoglycerides and free fatty acids. Lipoprotein lipase converts a VLDL particle into a VLDL remnant particle called an intermediate density lipoprotein, IDL. Monoglycerides and free fatty acids are taken up by the adipose tissue cells. Some intermediate density lipoproteins get reabsorbed by the liver, while others can be further modified. This further modification occurs in the capillaries by the action of lipoprotein lipase. As a result, more compact LDL particles are formed, and more free fatty acids get absorbed by adipose tissue. Once inside the adipocyte, 3 molecules of free fatty acids combine with 1 molecule of glycerol phosphorylcholine, or 2-monoglyceride, to form a triglyceride particle. In the adipocyte, the newly formed triglycerides are subsequently acted upon by hormone-sensitive lipase. This causes them to again disassemble into free fatty acids and glycerol. As a result, the increased amount of free fatty acids is again released from the adipocyte into the blood circulation. The free fatty acids released by adipose tissue become elevated in the bloodstream. These free fatty acids are then taken up by the liver, resulting in a vicious cycle.
Thank you.